Well, welcome today. I'm Lee Hamm. I'm Dean of the Medical School, and glad that you could join us for this educational forum on COVID that is really for students of all stripes and our residents and fellows. This forum is focused on you, although we'll make it available for everybody after the fact. You know, it's been an incredible last few months. It's been difficult, but also inspiring to see everyone's hard work. A lot of success stories on individual and particularly on group level successes here at the medical student. People engaged in learning, going about their programs, despite this very unusual circumstance, both with COVID, but with other both local and national challenges. And I won't take the time to go through them as I have on many occasions. But I want to commend you for your efforts and your resilience. I've recommended that we give everybody an A in resilience for the past many months. We're going to first go to Dr. Patrick Delafontaine, who's the executive dean at the School of Medicine, followed by our renowned Sharon Courtney, who has moderated now the 81st COVID informational forum, I think. But anyway, Dr. Delafontaine.
Patrick, you're on mute.
Yep. Thanks very much, Dean Hamm. It's my turn to welcome everyone this evening to this COVID-19 program put together particularly for the residents, the medical students, and our BMS students. We have an outstanding group of panelists today. I think everybody knows that things are moving extraordinarily fast with COVID-19. We're on the verge of getting emergency use authorization for probably 2 vaccines before the end of the year. We're hoping that we will get more in the early months of 2021. We are also have had a change in the quarantine guidelines, which has been good news. It is no longer necessary if one's been exposed to quarantine for 15 days. We can get into some of those changes during this session. So lots of things moving very fast. And so I think this is a very timely session, and I'm going to turn it over to Sharon Courtney, who's head of our government relations program at the university, and who's also a terrific moderator with a lot of experience in actually now in COVID-19. So thank you, Sharon.
Yeah, don't oversell the moderator, please. But thank you, Dr. Delafontaine. So I'm going to do quick introductions of everyone who's here today. You know our fearless leader, Dean Hamm, who has really helped keep us all headed in the right direction, our North Star during all of this. And Dr. Delafontaine, who's our executive dean, but also the PI on the Janssen and J&J vaccine trial. We have Dr. Kevin Krane, who's the vice dean for academic affairs, so all things students. Dr. Keith Ferdinand, who is the professor and Gerald S. Berenson chair and preventative cardiologist. He is an expert in cardiology and health disparities. I'm going to do my best here. Dr. Christine Bojanowski. Is that right? Okay, all right. Assistant professor, and she is an expert in respiratory issues related to COVID. Dr. David Mushatt, who's associate professor and expert in infectious diseases and has been a doctor working on the front lines of COVID. And Dr. Bob Garry, who is a professor, full professor at Tulane, and is an expert in our basic science and biology surrounding COVID-19. So a couple of quick things. If you have questions, please put them in the chat. And I'm going to start with questions, but first, before that, I'm actually going to let Dr. Mushatt start with a few slides he has, and then we'll get into questions.
Oh, that's okay, Sharon. I'll post my slides when it's my turn.
Oh, well, okay. All right, well, in that case, I'm going to start with Dr. Garry and just start with something basic, like tell us how COVID spreads and how long are people infectious?
Okay, the most important thing to know in this regard is that this is an airborne infection. Respiratory is in the name of the virus, SARS, and by far and away, the most likely way you're going to get infected with SARS-CoV-2 is through your lungs, through your airways. Now, early on, we learned that a minor way to get infected is by touching an infected object, and that's why hand hygiene is still important. However, wearing a mask and social distancing is the best way to keep yourself from getting infected. So how long are you infectious? Someone is most contagious once they've been infected with SARS-CoV-2 from about 48 hours before you develop symptoms, which makes this difficult because you can spread the virus before you even start to feel sick. And you generally tend to remain infectious for up to about 3 days after the last symptoms end. So CDC recommends that you can start being around other people after your symptoms gone away about 10 days if you've had a relatively mild course of the disease. And that, that's about 10 days after you've had no fever and other symptoms are going away. If you're really sick, though, the CDC recommends that you stay away from other people, particularly the ones that are most susceptible to developing a serious infection for up to 20 days.
Dr. Mushatt, do you want to follow up on that?
Indeed. So, you want me to start with my question, or just?
Oh yeah, sorry. I'm sorry. I was gonna. Sorry. See, I'm already falling on the job. Let me do it. No, our students and trainees are just a little younger than us, just a little. And I keep hearing that there's an urban legend that they should hope to get infected and get it over with because nothing bad can likely happen to young people. So is that true? And the follow-up is, can they be reinfected?
So it is true that young people tend not to get as sick. They generally either have no symptoms, they're asymptomatic, or they have very mild symptoms, but there are a small percentage that occasionally require hospitalization. Some require mechanical ventilation. Some develop the multi-system inflammatory syndrome, which is very serious, and some even die. So if you want to just take a look at the statistics here, this is from the CDC's COVID tracker website. And on the left, the graph in red shows you the percentage of cases by age group. And you can see that the 18 to 29 year old age group makes up about 24% of everybody with COVID as of the time of this analysis. If you look to the right, the blue graph shows the percentage of deaths. And, thankfully, the 18 to 29 year old age group represents only 0.5%, about a little over 1,000 deaths. It's probably higher now since this is already somewhat old. So compared to people over 50, 60, 75, etc., it's a relatively small number. However, take a look at this graph. This is from Scott Solomon's group at the Brigham and Women's Hospital, published in JAMA Network, one of their JAMA Internal Medicine. And they looked at a little over 3,000 young adults aged 18 to 34 who were hospitalized with COVID around the U.S. And what you see in this graph are the rates of death, the proportion experiencing death or mechanical ventilation, depending on whether they had no risk factors, 0, 1, or 2 or 3. And the risk factors are morbid obesity, hypertension, and diabetes. And even with no risk factors, you can see a little over somewhere between 1 and 2% died if they were hospitalized. But if they had 2 or 3 risk factors, it's between 6 and 7%. And so this article concluded that 21% of these young people who were hospitalized required intensive care, and nearly 3% died overall. So, the number is not trivial, and therefore I hope that young people don't get the idea that it's okay to get infected willy-nilly. The other thing to keep in mind is, regardless of the risk to you as an individual, as a young person, you can still transmit virus to your loved ones, to your family, older friends, professors, and others, and they obviously are at much higher risk for complications. And so, for those 2 reasons, we really don't want we don't want to buy into this urban legend. And then finally, I don't want to steal Garry's thunder, but the other just quick fact that comes into play here is that if you think you can get to herd immunity by just getting it over with and getting infected, let me just give you a quick back of the hand calculation here. If you want to get from 20% immunity, which we're probably at now, maybe, up to 60%, which is herd immunity, you'd have to infect 140 million more Americans. And of those, over 1 million people would die, and many would be hospitalized, many more. And so I think if you just look at that very simple math, you can see that just letting people get infected, as they did for a while in Sweden, is not the answer. It will lead to tremendous suffering, death, and morbidity. And so therefore, the vaccine is our best hope to get to that as soon as possible. Thank you. Oh, and then reinfection. So reinfection does occur. It has been documented around the world. It appears to be exceedingly rare, but what they do is scientists do genomic sequence analysis of virus, of the first virus and then the subsequent virus, and they're able to show that they're 2 different isolates. The data, there's very little data on the incidence of this. There is a preprint article from the country of Qatar that suggests that the risk of reinfection might be on the order of 0.01%. It's a very small piece of data. We need much better data, but I think the point is that it's probably going to be quite rare. Thank you.
Thank you. Dr. Ferdinand, can you tell us a little bit about what the long-term cardiac issues are from COVID-19?
Sure. Well, Dr. Garry already said it's a respiratory virus, but we know that the inflammatory state can be throughout the body. And in fact, persons with cardiovascular disease die more. And even younger people who don't have pre-existing cardiovascular disease, there have been some studies using MRIs, and they've shown almost half or more of them have some degree of inflammation. Now, that does not necessarily transmit to they're going to go into heart failure or have true myocarditis. In fact, we're thinking the real myocarditis, in which the virus enters into the myocardial cells and causes direct injury, is somewhat rare. But we now know that the inflammatory state is generalized. It's not just in the lungs. It does involve the heart. And we're thinking that perhaps some of the long haulers, those people who are always tired and just don't feel right, can't do what they used to do, get tired walking up the stairs, some of them may have subclinical myocardial disease. Perhaps what we should do now is not do MRIs on everyone. That's expensive, it's awkward. I don't think insurance companies will pay for it. And we're going to get a lot of false positives. But if a person has persistent symptoms, let's say 2 to 3 weeks after they have so-called recovered, then you may want to get a baseline ECG looking for some abnormalities. If they're really short of breath, an echocardiogram, seeing if they had decreased left ventricular function. And in some cases, we have seen elevation in troponin, similar to what you see with myocardial injury in patients post-COVID-19 infections. The other person are the competitive athletes, and I checked on some of the latest data on that. We really don't know what to do with them. The NFL is going ahead, college football is playing, and we need to watch out for some kids who may have had mild forms of disease, developed inflammatory disease of the heart, may have myocarditis, but continue to play. They're at risk for arrhythmias or even sudden death. So I don't think we should just go with, you got over it, you feel better, get out there and play ball. We need to be a little bit more sensitive to these conditions.
Thank you. Dr. Bojanowski, is there also potential for long-term lung damage?
Yeah, that's a great question. So we know that in the short term, even in the mild to moderate cases of COVID-19, symptoms such as shortness of breath, cough, fatigue, those can last anywhere from 2 to 6+ weeks. We know from previous experience with like SARS and MERS that 30 to 50% of those individuals that were impacted had persistent pulmonary respiratory issues several months out. We've made a tremendous amount of improvement in terms of our ability to successfully treat and care for patients with COVID-19. That's definite. And I think even with our sicker patients, the ones that are admitted to the hospital or to the ICU, we're seeing that more people that are hospitalized will eventually recover. I think it's really important to put everything in perspective, just pointing out that we really are just the 1 year mark about of cases overall and being able to review data. So in terms of long-term consequences in the lung, the short answer is probably a strong yes for damage potential. However, the extent of this is really yet to be determined. We're probably going to see things like shortness of breath, chronic cough, in patients that have very severe COVID disease, pulmonary scarring, fibrotic lung disease. We'll see some airway architecture damage, bronchiectasis, and probably pulmonary vascular disease related to the increased incidence of blood clot that we're seeing. There are a lot of studies that are ongoing now. There's a really big study going on in Europe that's trying to enroll like 10,000 patients that have been discharged from the hospital to get a better idea of what the long-term lung sequelae is.
Thank you. Dr. Delafontaine, so all we hear about now essentially are that vaccines are on the way. And that the first line healthcare workers, frontline healthcare workers will likely be the first ones to receive them. Can you tell us a little bit more about the state of vaccine development and release?
Yeah, I mute myself. Yes. So the first vaccines are on the way. I think most folks know that Pfizer and Moderna are going to be the first to get emergency use authorization by the FDA. That doesn't mean that the vaccines will get full approval, but it means that they will actually be able to be used. There's an allocation of those vaccines that's going to be based on a number of factors, and they're going to go out to all the states. We anticipate that we will be getting a vaccine in Louisiana in the next few weeks, and each hospital facility will get a small allotment. We anticipate that over the next few months, we're going to have several others become available. In particular, Johnson & Johnson has a vaccine that's currently being studied, and we think that one will become available as well. The initial amount of vaccine that will be available by the end of the year will be a little less than what was hoped for. I think the federal government had hoped that we'd get about 100 million doses of vaccine by the end of 2020. It's probably not going to be more than half of that because of some manufacturing challenges, etc. To reiterate what Dr. Mushatt and others said about herd immunity, I think we heard that herd immunity through a natural infection is not the answer. Herd immunity through a natural infection would result in over 1 million deaths in the United States alone. But herd immunity through the vaccine is the answer. Remember that when one gets vaccinated and the initial efficacy data from both Moderna and Pfizer show that those vaccines are over 90% effective. So with that level of efficacy, if enough of the population gets the vaccination, we're going to get to herd immunity. Hopefully, if things go as planned by summer, maybe a little before summer, but hopefully by summer 2021.
So There was a question in the Q&A, and Dr. Mushatt answered it, but I want to go ahead and make sure everyone has seen it and hear his response. And Dr. Delafontaine, if you have one too, but it's like some rumors question the credibility of the vaccines. Could we address, you mind addressing how a COVID vaccine was made possible within a year while we have been researching HIV for years and have yet to create a vaccine or treatment for that? So I'll start, Dr. Mushatt, I'll start with you since you had answered it in the Q&A.
Sure. So, I mean, it's a good question. So keep in mind that HIV is a totally different virus from these respiratory viruses such as corona. HIV mutates much faster. It integrates into the host DNA, human DNA. So it's a much more difficult nut to crack. It's much more challenging. Coronavirus has been around a long time, and they really do lend themselves well to these newer technologies such as messenger RNA and adenoviral vector technologies, which are can be developed very quickly once we know the sequence of the virus. But in addition, what we're doing this time that we haven't ever done before is we're overlapping the different phases of development. So instead of proceeding very methodically from phase 1 to completion, phase 2 to completion, and then phase 3 and on, they're overlapping these phases in a very efficient manner that allows for really record time development and movement forward of these vaccines without sacrificing safety. They're still getting the safety data. They're getting the efficacy data, both in vivo, looking at antibodies and T cells, but also looking at actual efficacy in terms of whether the vaccine prevents infection. So I think it's just a whole new ball game. HIV is just a much more, it's a much clever virus, if you will, in terms of its ability to evade the immune system and to infect the host. They're just two different things. I think in terms of credibility, I've listened to a lot of podcasts from very distinguished people such as Carol Baker, who's a very senior, highly respected vaccinologist at Baylor. And she said she's ready to take it right now. She's looked at the data. mRNA and adenoviral vaccines have been around for a while. mRNA vaccines have been used for Zika, chikungunya, CMV, the list goes on. The adenoviral vectors have been used for a while for Ebola and others. And while the numbers are not huge, the data to date shows that they are very safe. And they do not cause infection in people. They do not appear to cause serious side effects. And certainly, people are going to have some flu-like symptoms after the vaccine, just as you would with the flu vaccine. You're going to have some headache and fatigue and maybe a little fever, but it's a small price to pay, as Carol Baker said, for protection against serious complications and even death.
Does anybody else want to follow up on that?
Perhaps the only thing that I'll add to that very nice discussion is that the severity of this pandemic worldwide has resulted in governments putting a huge amount of resources into vaccine development. We're talking about tens of billions of dollars, both in the United States as well as in European countries and other countries. And so that has been also one of the reasons why the pace of development of these has been really quite spectacular. Several of these vaccines have already had extensive testing in non-human primates, which are large animal models, if you will, before they went to humans. So really tremendous investment in these vaccines. And if one looks at the numbers, there's now 51 vaccines in clinical testing and 163 additional vaccines in preclinical testing at the last count. So just a huge amount of investment worldwide in vaccine development.
We've got a few more questions that are coming in the Q&A. I'm not quite sure who this should be for, but maybe Dr. Garry or Dr. Delafontaine. Do we need a COVID test before taking the vaccine, or can a COVID positive or post-infected person get the vaccine?
I'll send it to Patrick, Dr. Delafontaine, sorry.
So no, you don't need a COVID test. Now, some of the clinical studies are doing it, but it doesn't exclude one from the study. You can definitely get the vaccine whether or not you're positive. So it's not required. And if you think about how we're going to give this vaccine out, once we get enough of vaccine, we're going to be immunizing the population at large without testing them for SARS-CoV-2. And as Dr. Garry and others have said, there's a very significant number of folks out there that have the infection and that are totally asymptomatic. So it's not required, I guess, the main message here, it's not required to get a COVID-19 test to get the vaccination.
Dr. Ferdinand, there's a fair amount of press, although probably not enough, about historically underserved populations being disproportionately affected by COVID-19. Can you tell us a little bit more about that and what the facts are on that? And if so, if that's true, why is that true? And you're on mute right now.
COVID-19 did not cause a lot of these disparities. They've been persistent for decades. If you look at national health statistics, there's been a white-black death gap for several decades where Black men die 4 to 5 years before white men. Black women die 2 to 3 years before white women on mean. And that's driven mainly by cardiovascular disease. It's not drug use or drive-by shooting. COVID-19, however, does tend to hit persons who are in certain situations. What are those situations? The so-called essential workers, the grocery clerk, the bus driver, the delivery person, because they're coming into contact with a lot of people. And early on in the disease, we really didn't recognize how dangerous the transmission was. So that's one thing. Also, if a person lives in a multi-generational home with not just the mother or the father and young children, but it could be the uncle and the grandparents, then the likelihood of a person who's 65 years of age and older, along with a comorbid condition, increases. The other is the way we first diagnosed COVID-19 early was doing suburban mall drive-through testing, where people would get in a car and go out to Metairie, or if you in Washington, D.C., you'd go out to Langley or somewhere away from the city and get tested in your car. Well, a lot of people who live in the cities and urban areas don't have a car. We saw that in Katrina, where 40% of people weren't able to evacuate. And those are the people who drowned and died. So there's a lot of what we call social determinants that explains that. I think we're doing better now. We're doing some drive-by testing that's in the city itself at the municipal auditorium. They're doing some walk-in testing also. And we're making people more sensitive that if you have grandma, grandpa, uncle at home, then you have to be a little bit more cautious to the extent you can. A lot of the essential workers can't work out of their office, so they can't really distance themselves from the public, but hopefully the markets will continue to give them the appropriate protection, put up the guards, and the public will stay with the face mask mandates and protect themselves. One other comment, and I'll do this very quickly. The vaccine is not going to reach herd immunity in the United States unless we reach these disadvantaged populations. If you look at the Black population, 13%, Hispanic population, 15%. So you're talking about 25, 30% of people are so-called minorities. If they don't embrace the vaccine, if they feel that it's not for them, then you've already knocked out 30, 35% of the population in terms of reaching herd immunity. So we need to do a lot of education and outreach with disadvantaged minorities who feel that the vaccine may be dangerous, or targeting them disproportionately for the wrong reasons, because if we don't have uptake, then we're not going to be able to protect everyone.
Can I just ask you a follow-up question on that? Sort of like, what is, given the reasonable historic mistrust of vaccines and other things from underserved populations, what is the best way to educate and reach them on this?
Well, I think we in academia need to get into the community and find what we call trusted messengers. It's a term of art that's developed out of NIH. Those are persons who have a history of working with the community. It's not necessarily doctors. It could be nurses. It could be ministers. It could be everyday persons, community activists, and educate them about the benefits of the vaccines. And then they become the messenger to help educate the public. If we don't do that, I could see where you would have limited uptake in the minority community. And again, it doesn't necessarily mean that it's just going to hurt them. It hurts the whole concept of herd immunity. One more comment. This is a crazy talk comment, but it's, you can go and do your own quote Google search. A lot of the anti-vax stuff comes out of Russia, the same people who mess with elections and try to get you to not believe that democracy is a good way of modeling how we should run our country, tell you that vaccines are dangerous. So a lot of that's still the same type of disinformation.
Thank you. So another question from one of our audience members is, to what extent do existing antibodies impact eligibility and safety for getting a vaccine? Was that trial exclusion criteria? I'm not sure who should take that.
I think Dr. Delafontaine already answered that. I mean,
oh, did he? Okay, I'm sorry.
We're not going to test for, you know, whether you've had SARS-CoV-2 infection before. We're not going to look for antibodies. We're going to try to vaccinate everybody. As Dr. Ferdinand said, we definitely need to get into all the different communities because he's exactly right. We need to get to somewhere around at least 60 to 70% coverage with the vaccines to achieve that goal of herd immunity, so that the pandemic will basically wind itself down and go away.
And then, is there any data or timeline on vaccination during pregnancy?
Dr. Delafontaine?
To my knowledge, most of the clinical trials have excluded pregnant women from participating. That being said, some pregnancies have occurred early on in the trials because that's just the way clinical research occurs. And so there is a little bit of data starting to accumulate, and we will be getting more and more. Right now, it does not look like there's been any negative effect of getting a vaccination if one is pregnant. But again, this hasn't been formally looked at yet. It is being studied.
A good reference. Oh, I'm sorry, Sharon. I was just going to say a good reference, because this has come up a couple of times, but a good reference is the Society for Maternal Fetal Medicine. They update regularly. They had a kind of a little call on 12/1, just advocating for more pregnant people to be included in studies moving forward. But that website, I'll just share it in the chat box, but it's a good resource.
Thank you. We had one other vaccination question we're just going to get to in the Q&A, which is, to what extent are preclinical, if at all, and clinical med students considered priority in being vaccinated after essential and high-risk groups are covered? I assume, Dr. Delafontaine, that would be for you.
I think Dave Mushatt may be able to answer in addition, but I think the state is following the CDC guidelines as far as initial vaccination priorities. So that's people living in long-term care facilities and the staff, as well as frontline healthcare workers, so providers and staff taking care of patients on the front line, and who thus have a much greater chance of being exposed to COVID-19. And then there will be a next phase of essential workers, people with comorbid conditions or vulnerable conditions, and those over age 65. It's unclear to me where med students will fall in that, other than, of course, if they're taking care of patients on the front line, they would then fit within that first category. Residents that are, for instance, in the emergency room or working in the ICU are going to be part of that first high priority category to be vaccinated. We've stayed away from students directly taking care of COVID-19 patients, but obviously those working in the ICU, you know, are going to be at a higher risk. And I don't know if Dr. Krane wants to add something on that.
What I'd say is, like you, we're waiting to see what the guidelines are. Our current institutional guidelines are that we don't have medical students taking care of COVID patients. And we've been asked by medical students about that, particularly because in their altruistic approach, they want to provide that care if necessary, which is commendable. We're really looking at national guidelines, and the current guidelines came from the American Association of Medical Colleges, the AAMC, and that really hasn't changed in that they still do not recommend medical students provide care for students. On the other hand, we have heard that there are some institutions that are making changes to that. And the other big issue that's come up, which really is a very practical one, is we do have to prepare our fourth-year medical students who will be graduating and almost certainly will be taking care of patients with COVID-19. So we're going to build some of that into our transition to residency elective that a significant number of students have signed up for in the spring to be able to do that. And because this is such a dynamic issue in terms of what should we do in terms of preparing students for care with COVID-19 patients, we are also looking at are there situations where it may be in the benefit of students to participate in obviously a very safe way with appropriate PPE and so forth.
Dr. Krane, that's a very detailed and thoughtful answer. Each of the states makes their own decision. We say we follow CDC guidelines, but it's actually going to be a state guideline. The CDC will give us a certain percentage of vaccines that are available, and then the state makes its decision. I would think that medical students would not be in the first 2 or 3 aliquots of vaccine in a given out, but you made a point that maybe we should look at seniors who are about to enter the clinical care towards the end of the spring.
Yeah, actually, but that's not really for so much for the vaccine administration, but I do get asked a lot of questions from students about can we take care of COVID patients? So I do want to address that a little bit. And at the present time, we are not having students provide care for COVID patients. That all may change in the future because this is a dynamic situation. But you're absolutely right. We're not going to do anything that's different than the guidelines that are provided to us.
Dr. Mushatt, can you give us a little bit of information about the current state of treatment surrounding COVID? Mute. You're on mute. Sorry.
Absolutely. So there's one agent that actually has been shown to reduce mortality, and that's dexamethasone. It's a steroid, and it's been shown to reduce mortality in patients who are hospitalized with COVID by up to about 34% if you're very sick, say on a ventilator, and about 17% if you're just on oxygen. So that's some really good news. Dexamethasone appears to be widely available, plentiful in supply during these times of oft shortages, and is not super expensive. So that's great. Now, the other interventions would include remdesivir, the first antiviral that received emergency use authorization. It has not yet been proven to reduce mortality. It does, for instance, in the Solidarity trial, it did show a reduction in the time to recovery from something like 18 days to 11 days. But the jury is still out as to whether it actually reduces mortality. And in fact, the WHO currently does not recommend its use for the reason that the data just is not overwhelming enough. It's very expensive, etc. But we try to give it to people that are able that meet the criteria. When we have enough of it, there are occasionally shortages. It's unclear whether it's really going to be transformative. It may be that you have to give it very early in the course of illness. That's true for a lot of these antiviral regimens. Just think about the flu. If you don't give Tamiflu or oseltamivir within the first 2 to 3 days after somebody gets the flu, it doesn't do much good. Once you wait 3 or 4 days, it's virtually useless. May help a little bit in some people, but you have to give these things early, and people don't always present early because they put off going to the hospital. They don't want to come in right away. Other things that look promising are the monoclonal antibodies. They have received emergency use authorization, but only for ambulatory patients. They cannot be in the hospital. They cannot be on oxygen, so they cannot be very sick. And these two have not shown a reduction in mortality, only they seem to reduce the need for hospitalization and ER visits. So the jury is still really out on the Regeneron and Lilly monoclonal antibodies. We do have clinical trials of these here at Tulane UMC, and I encourage people to participate. Convalescent plasma is used by a lot of people. It is possible to use it through the EUA program. It's still, the data is still equivocal. I'm not a huge fan of it, but it may be that it works maybe in certain subpopulations, which we haven't properly identified yet. It will be helpful. The Solidarity trial, again, which is this big consortium overseen by the WHO recently, pretty much put the death knell on hydroxychloroquine, lopinavir, ritonavir, and interferon beta. I think they concluded that those are not likely to be of any benefit, so we can move beyond those. There is, some hope that maybe famotidine, the H2 blocker, might be beneficial. There's some signal, but no real clinical outcomes to support that. Vitamin C, vitamin D, and a host of other approaches and new antivirals, et cetera, that are further down the pathway. But bottom line is steroids do significantly reduce mortality, and we're waiting to see whether monoclonal antibodies will reduce mortality once we get enough people on those. And so we still have a long way to go.
A convalescent plasma report was just sent out. I don't know if I sent it to you, Dr. Mushatt, but it was negative. It was done at Harvard. Now, these patients were fairly critically ill. They had been in the hospital for 8 to 9 days, and perhaps they were too late in their disease process to get benefit. I was asked to be an informed person for plasma infusion in the community, go out and tell the community they need to come in and get that. And I felt uncomfortable about it. That study really made me even feel less comfortable about doing that as a main message. Not that it's a bad way of treating patients, but if we don't have vaccine uptake, then the ball game is going to be lost.
Right. It's kind of the old saying when HIV, in the early days of HIV, it's the virus, stupid. And what I mean by that is that when the viral load is high, when there's a lot of virus in that first couple of days, maybe first 5 to 7 days, that's when your antivirals are most likely to work. And after that, they probably don't benefit you very much. And so plasma, being essentially an antiviral, probably doesn't work when, if they're giving it an average of, or a median of 7 to 9 days. It probably has to be given very early, and that's a difficult thing to implement in our healthcare system, getting that out real early. But there's still maybe some role for that. I think the most challenging part of COVID in many ways is figuring out which patients benefit from which treatments and which combinations of treatments. Just as with HIV, AZT did not save any lives when it first came out. It wasn't until we discovered that people had to be on 3 medications that we actually started saving lives, and that took years. And so that's what we're looking at with COVID, is probably using combination approaches, but it's going to take time to sort that out, so we have to be a little patient.
Thank you. Dr. Bojanowski, if students have to undertake air travel for the holidays, what are some of the things they should do to be safe in airports and on airplanes?
All right, so that is a topic that comes up quite a bit, right? So of course you want to keep yourself and your loved ones safe. And the best way to do this is to minimize unnecessary travel. But if you are planning to undertake air travel this holiday season, there are a couple of websites I would recommend you check out before you go, namely the CDC website and the state and local health department websites of your destination. Leading up to the travel, these are some recommendations that really were taken from the CDC. I think it goes without saying that don't travel if you're sick or if you are COVID positive. You want to make sure that you check the state and local travel restrictions before you go. And again, the state and local health department websites are going to be the best resource for this. You want to make sure that you're cognizant and aware of whether cases are really spreading at your destination. You want to understand the testing and quarantine requirements of your destination. You want to think about, are you at increased risk for severe illness? Or do you live with someone, or are you visiting someone that might be at increased risk? And you want to be checking back for updates on these websites closer to your trip. The CDC has a couple of other recommendations. One is like during the couple of weeks prior leading up to your travel, you just want to be extra conscious about limiting your exposure risk. So avoiding large social gatherings, restaurants, bars, fitness centers. You want to make sure you're up to date on getting your flu shot, everything like that. And the CDC also recommends that you consider getting tested either 1 to 3 days before your actual trip and 3 to 5 days after your trip. And that's also in the setting of reduced non-essential activities for 7 to 10 days afterwards. While there are risks associated with flying, I think there's been a lot of discussion about this, but the flight itself with the right precautions is likely much safer than you think and safer than the airport terminals themselves. So the greatest exposure risks are likely going to be in the airport terminals, in the security lines, when you're boarding, when you're deplaning, for example. So when you're at the airport, there are a few things that you can do. One is wear a mask at all times. These are mandatory on all airlines, at all airports. If you have a fit N95, you could use this. If you are wearing a face shield or glasses, do this over or in addition to your regular mask. You want to make sure you're bringing extra supplies such as masks, hand sanitizer, disinfectant wipes. Remembering that the TSA is now allowing us to use 12 ounces or bring 12 ounces of hand sanitizer on our carry-on luggage. And you want to do all of your good pandemic hygiene practices, right? So avoiding close contact to other people that aren't in your immediate travel group, maintaining 6 feet apart, 2 arms lengths from anyone else, and paying attention to frequently touched surfaces like the kiosks, elevator buttons, handrails, all of those things. Well, you want to wash your hands often, use hand sanitizer, and pay attention that you're not avoiding touching your face, your nose, your mouth, and all this, which again is in line with normal, good pandemic hygiene. On the airplanes, there's actually a lot of very interesting articles that you can find on JAMA and also the Journal of Travel Medicine. There's some great information also on the FAA, IATA, those are all through the airlines and airports. But there's been a lot of publications on airflow and HEPA filtering used on the commercial jet airliners. So air enters a cabin from overhead inlets and then flows downwards towards the floor level outlets. And so the air enters and leaves the cabin pretty much the same row or nearby rows. So there's not a lot of longitudinal or front or back kind of airflow or contamination on flights just by the airflow on the plane themselves. Half of the air on planes is fresh from the outside, half is recycled through HEPA filters similar to those that are used in ORs. And I found it to be really interesting to know that the total air volume in a plane is refreshed like frequently, every like 2 to 4 minutes or 20 to 30 times per hour. So I thought that was a really interesting point. And just lastly, a couple of things like when you're actually on the plane, just to follow this out, I mean, this is a really easy, lots of discussions about this, but social distancing is really nearly impossible on a flight. Not every airline is leaving the middle seat empty either, right? So that's just one thing to be aware of and mentally prepare yourself for. Before you sit, get comfortable. It's a good idea to use sanitizing wipes on your seat, your armrest, your tray table, the lights, the nozzle, the gasper above you, which is the air filter thing, and all of those high touch surface areas. Again, you want to think about the fact that boarding, deplaning, and moving about the cabin are what put you in the highest risk for close proximity contacts, right? So to this point, if you had to pick a seat, the window seat is going to be preferable if that's a possibility. You want to avoid any unnecessary movement during the flight, meaning like don't go up and down the aisles. That's going to kind of shift the way the air flows anyway, and just puts you in more contact with people, on the flight. So what does that mean? That means use the bathroom before getting on the plane. Try to do things that minimize demasking time. So eat, drink before getting on your flight. If you are going to do these things on your flight, you might want to just keep in mind that, that time limit of about 15 minutes to kind of just keep everything on and off and just limiting your time without having your mask on. So those are some of those things. Is a big discussion point. There are a lot of good resources out there that go over this. But again, really just re-encourage you to check out the CDC guideline website before you go, and check out your local and state health departments of your destinations.
Thanks. I thought I missed flying until that. Now I actually don't right now. So Dr. Mushatt, so now people are home and we know about spread among adults typically, but can you tell us if children are able to spread infection as well?
Yeah, so of course kids can also spread infection. There's been a lot of debate about their relative role in this epidemic. And if you really want to look at a very nice discussion, the December 1st issue of the journal Pediatrics has an article, some data, and then a very nice editorial in which they state that the fiercest debates waged in both academic and public arenas concern the relative ability of children to acquire and transmit SARS-CoV-2. And then they go on to say that the preponderance of current data still indicates that children have reduced susceptibility and infectivity compared with adults. So there are some studies that the studies are kind of murky, but one pattern that's been seen is that younger children may be less likely to transmit than older kids and teenagers. A lot of studies have shown plenty of virus in the nasal passages of children, but it may be that since kids are more likely not to have symptoms or to be asymptomatic, perhaps they just don't aerosolize as much. They don't spread it as much. The bottom line is they do play a role. It's some say they're even an unrecognized group that are both vulnerable as well as play a role in spread. The data I think is still not entirely clear, but bottom line is yes, they do play a role, and so we need to educate our kids to wear their masks as much as they can, and of course do testing where appropriate.
So Dr. Krane, when med students, residents get back from the holidays, will anything be different from the fall semester COVID response as far as students and residents and fellows are concerned?
Well, I can address the students. We already are set up, because the medical students come back earlier than the undergraduate campus, that we want all of the students coming back to get tested with as soon as they can from their vacations or from wherever they're going back to their families. So that will be available immediately. The one big change we are going to make with teaching is that we are going to provide some opportunity for some hybrid classes for first and second year students to come in limited numbers, in large spaces, to have some in-class presentations that will be given both on Zoom as well as in person at the same time. So we're ready for testing for when everybody comes back, and I think that's available to everybody.
Dr. Garry, what about BMS students, both in classes and bench research?
So I really don't see any reason to change what we did this last semester at Tulane. What we did worked, and it worked very well. We had frequent testing. There was a lot of thought to put into how we're going to manage the classes, how we're going to manage the research enterprise. And it was just a remarkable accomplishment all around to get the testing up and all the other procedures, the contact tracing, et cetera, into place. So my advice is let's do what we did this last semester, and let's get through the spring semester, get everyone a vaccine, and then let's move on from this pandemic. I think the next few months are likely to be pretty tough until we get till we get people vaccinated and we reach that level of population immunity, herd immunity, whatever you want to call it. So we're in for a lot of new cases that are going to come. It's already happening in other parts of the country. We could, and there's upticks here in Louisiana too. We need to be very vigilant. It's not time to let down anybody's guard. Let's get through this next month, get people vaccinated in all our different communities, and move on from this pandemic.
So question in the Q&A block, which I think is probably for Dr. Mushatt. It's like, it's hard to tell the future, impossible to predict the future. But as of now, are we expecting a surge in cases and hospitalized patients for this month and holiday season in New Orleans? And if so, how bad do you think it's going to get?
Well, yes, we're actually on the upslope of another wave or surge. There's a lot of debate about whether this is really a surge, but the bottom line is that the whole country is experiencing this. We're a little bit better off. We're a little bit, it's a little bit less severe here in Louisiana, New Orleans, and other parts of the country. But yes, we are experiencing this increase. It's a secular trend. It's going to go up. My favorite model is Professor Reich's model at the University of Massachusetts. This is the ensemble model, very much like the ensemble hurricane model, where it combines many of the models, not all of them, but many of them. And also Mike Osterholm at CIDRAP, this is the Center for Infectious Disease Research at the University of Minnesota, recommends this model as well. And they show cases peaking at the end of December in Louisiana, later in other places. So I'm hopeful that, in early to mid-January, we'll see an abatement of this. To some extent, it depends on how well we did during Thanksgiving, because we're now at that 10 to 14 day point post-Thanksgiving when we may start to see some increase. But yes, I think it's better to assume the worst. It's going to get worse. There will be more hospitalizations and more cases in the next couple of weeks. I don't think there's any getting around that. And no matter what we do now, remember, there's that lag. Even if we shut down everything right now, there's still a 10 to 21 day lag in what we see in the hospitals. And so we do need to be curtailing some of our activities now, but it's not going to help in the next couple of weeks. We're doing this to get through the next couple of months. But on the other hand, the vaccine's going to be coming, will be deployed during the same time period. But remember, it's going to take time for that to get rolled out to people. It requires the Pfizer and Moderna vaccines require 2 doses, so you're really not immune probably for 5 or 6 weeks after the first dose. And so if you think about it, it's going to be a few months before significant numbers of people have vaccine-induced immunity.
So real quickly, Dr. Garry and Dr. Krane, if students have concerns about COVID-19 safety or processes, who should they be in touch with?
For the medical students, the easiest thing, for the most part, Dr. LeDoux, our Associate Dean for Student Affairs, has really been the COVID go-to person in terms of keeping track of all the students through student affairs. But the easiest thing is send an email to both of us. Everybody knows where to find us on email, and we'll make sure any question is addressed directly and quickly.
And for the BMS students, you can also send me an email, rfgarry@tulane.edu, or you can contact Dr. Blake@tulane.edu, or contact the BMS office if you have more general programmatic concerns. We're trying to be as available as possible.
Great. Thanks everyone for being a part of participating in the town hall tonight. I'm going to turn it back over to Dean Hamm.
Thank you very much, Sharon, and thanks to all the panelists. I'll tell you, these continue to amaze me. They were excellent questions, very insightful questions, and really amazing panelists. I don't know why I'm continually surprised at the expertise we have, but I learn something every time, even though I'm trying to stay up on things from many different directions. But anyway, it's we do. If you have other questions, as you heard, there are many avenues to find out. Let me remind you to continue to take care of yourselves, both physically. That's in terms of being COVID responsible. We need to have all of you modeling good behavior as representatives of the medical school in terms of masks, socially distancing, hygiene, all of those things. Communicating well, people will turn to you as sources of information. You've heard a lot of good information. And the way to fight bad information is to provide good information. And if you need more, you've certainly heard where to get it. Let me, in terms of taking care of yourselves, you know, this, the stress, you know, the fact that the vaccines are in the weeks and months ahead hasn't relieved all the anxiety and other factors that come with that. So take care of yourselves and also those around you, whether it's family members or friends or classmates. Be certain to let us know if you or someone else is struggling. Don't struggle alone. There are avenues, both formal and informal avenues to get help. And we want to make certain that we take care of ourselves as we try to take care of the community. Thank you very much. Have a good rest of the evening. Thank you.
Thank you.
Thanks, everyone.
Thank you.